Are you trying to get more information on thiamine deficiency and whether or not that's affecting some of your health problems? My name is Dr. Taranella, and in this video, we're going to look at some of the signs and symptoms of thiamine deficiency and also the potential genetics causing thiamine deficiency. Again, my name is Dr. Taranella, and if you're new to this channel, I just want you to know that I make these videos to help you go beyond the basics of your health, whether it's a confusing lab test, symptom, or diagnosis. I make these videos to help you get a better understanding of what's happening with your body and your health. So if you like this kind of information on nutrition, health, hormones, etc., click on the like button and don't forget to subscribe to the channel to get more videos like this one. Now for a quick disclaimer, the information contained in this video is for informational purposes only. It's not intended as treatment for any medical condition or a substitute for seeing an actual doctor or medical professional. It should be used as an educational guide to deepen your understanding of your own health and treatment success. If medical attention is needed, don't delay in seeking that attention. All right, let's look at the potential genetics causing thiamine deficiency. So in this video, we're going to look at some of the causes and genetics causing thiamine deficiency. So thiamine deficiency is quite rare in the United States. The NIH, or National Institutes of Health, estimates that only about 1% of adults in the U.S. have thiamine deficiency. Yet some people have a subclinical thiamine deficiency, and this is less reported on and more difficult to diagnose and test. So really what we want to do is look at how many people can potentially get health improvement from thiamine. There are certainly groups of people that are more at risk for thiamine deficiency, including people with alcoholism or those that just consume alcohol on a regular basis. Older adults as well, due to poor absorption. People with HIV and AIDS can sometimes have issues with absorption, and sometimes medications can also interfere with thiamine absorption as well. People with diabetes or consume high amounts of carbohydrates, and people that have had bariatric surgery are also going to have difficulty absorbing thiamine depending on which type of surgery they had. Another area to look at that may affect your need for more thiamine is your genetics, the genetics around thiamine absorption and utilization. So there are some genetic alterations that may cause one to need to test for thiamine or be more suspicious of a thiamine deficiency. So we'll look at how thiamine is used in the body first, and then go into some of the genetics, which there's a connection there between how it's used and some of the genetics as well. But thiamine is transported into the cell via thiamine transporters. They're referred to as THTR1 and THTR2. They're encoded by two different genes, SLC19A2 and SLC19A3. Both of these genes can be mutated and can cause known negative impacts, and they can also be polymorphic in that they may cause more common but also increased need for thiamine. So once the thiamine is absorbed into the body, it is then converted into its active cofactor, referred to as thiamine pyrophosphate, or PP for short. The active form is formed inside the cell, and the enzyme that does this is called thiamine pyrophosphokinases, also abbreviated TPK1. And this enzyme, the TPK1 enzyme gene, can also be polymorphic and be mutated as well. Just as an aside, I'm using those two things separately. Polymorphism is usually something that occurs in the population in a broader sense. So a lot of people may have it, or it's more common, and could still lead to significant changes in how our bodies process things, but usually not as detrimental as the mutated forms of genetic alterations. So once the TPP is formed, that active form of thiamine is formed, it enters into the mitochondria to do some specific actions, and that TPP needs to be transported on a transporter molecule, and that is called TPP transporter. The TPP transporter is encoded by another gene called SLC25A19. And it carries the thiamine, the active form of the thiamine, into the mitochondria, where it can be used in the Krebs cycle and other functions where it helps with the breakdown of energy sources, turning those energy sources into actual energy. So that thiamine transporter can also be mutated or have polymorphic aspects to it as well. So there's three main areas that can be genetically altered and lead to an increased need for thiamine at the level of absorption from the digestive tract into the body. And then once it's absorbed, turning into the active form. And then once that active form is produced, getting it into the mitochondria. So these three different genes are called SLC19A2 and SLC19A3. So that's one, the TPK1, and finally the transporter of the active form, which is SLC25A19. So each of these different alterations are associated with inborn errors of metabolism, which is a major problem. For instance, the SLC19A2 defects in childhood will result in basal ganglion disease. And as with a lot of these thiamine deficiency and thiamine genetic alterations, it's going to affect the nervous system a lot. So they'll have encephalopathy, coma, epilepsy, and generalized dystonia. The classic form of this is referred to as Lee's syndrome. Adult presentations can occur and it'll present more like Wernicke's encephalopathy, which happens from ongoing chronic alcoholism. In this case, it's just ongoing chronic thiamine deficiency, and can also result in encephalopathy like lack of balance, coordination problems, and trouble walking. You can also see it having major impacts on cognitive function, alertness, and general mobility. Because thiamine is essential for energy production, and the brain and the nervous system needs a lot of energy, this is a common place where symptoms are going to show up and manifest. The TPK1 genetic alteration can result in thiamine metabolism dysfunction syndrome 5 in childhood as an inborn error of metabolism. To date, not many cases of this have been reported, but it is conceivable that subclinical cases of this do exist into adulthood as well. Because this genetic alteration is creating the active form of the thiamine, testing the blood for TPP levels may be useful if you have SNPs along these lines and enough suspicion there, meaning symptoms that sort of mimic thiamine deficiency. And LabCorp does offer a TPP test. There are specific handling rules too to be aware of when you're doing that test. And then finally, the SLC25A19 results in an inborn error of metabolism as well, called Amish lethal microencephalopathy. Other presentations have been discussed outside of the Amish community, but most of the known cases have been severe presentations. So yes, all of these genetic alterations, when it's a major genetic alteration, results in major inborn errors of metabolism and problems in the nervous system that are going to be ongoing. But these genes also can be polymorphic and have different SNPs that may be limiting your utilization of thiamine. So you can see more subtle presentations of this. Other than doing a blood test for thiamine and finding a deficiency, which is very uncommon, how do you know if this is contributing to your health? Another common sign in these more severe cases is elevated lactate. So if you have ongoing lactate, whether it's in the plasma or the urine that's above what you would expect or above the reference range or close to it, that may be a clue that this thiamine deficiency could be going on. Thiamine is also a cofactor for pyruvate dehydrogenase. Pyruvate dehydrogenase makes acetyl-CoA, and if that enzyme isn't active, basically your body shuttles more of that energy into lactate. So elevated lactate could be indicated because of the deficiency at the pyruvate dehydrogenase. In a similar way, lactate dehydrogenase can also be tested and looked at as an indicator of thiamine deficiency. Looking at your genetics for this can directionally be helpful, but a full list of all the RSIDs and SNPs has not been fully documented. Still, I do think this can be a useful tool with very little downside risk if you do have a lot of indicators, meaning symptoms and some of these signs that are suggestive of thiamine deficiency. So how did that help you better understand some of the potential genetics causing thiamine deficiency? Hopefully it does. If you do have follow-up questions on this, drop it in the comment section. Be curious to hear what those questions are and if you have any other input on this topic. Thanks again for watching. We'll see you next time.